Hello and a very warm welcome to Rajya Sabha Television. You're watching a brand new edition of To The Point with me, Frank Rausan Pereira. Prime Minister Narendra Modi, in his Independence Day address on the 15th of August, said that the Ayushman Bharat National Health Protection Mission will be launched on the 25th of September this year. And to talk about this, I have the program CEO with me, Mr. Indu Bhushan. Thank you so much for joining me on Rajya Sabha Television and welcome.
Thank you for having me here.
The NHPM or PMJAY, as it is now known, is an ambitious scheme. It's a scheme that is being touted as a game changer and a scheme that is going to help several crores of people. You know, talking about the scheme, why don't we start off by talking about the salient features, really?
Okay, when we talk about the salient feature of a scheme like that, there are three elements. One, what is the population it covers? Second, what is the coverage it provides? Third, what kind of benefits it provides? So, number one, the population covered is 10.74 crore families or more than 50 crore people. And in terms of the benefit coverage, we have identified 1350 packages which cover 23 specialties and all major diseases that or health conditions that require hospitalization. Those are covered, and the coverage is 5 lakhs. 5 lakhs for a family for a year. In addition, one other key feature of the scheme is national portability. So anyone living in Bihar or from Bihar goes to Mumbai, falls sick, that person will be covered in the empaneled hospitals in Mumbai, and of course vice versa.
Talking about these empaneled hospitals, are private hospitals also included?
Of course. We can't have a scheme like this and provide services at this scale without the participation of private hospitals. If you look at the healthcare seeking behavior in the country right now, 70% of healthcare is provided by private sector. So private sector is a key element of our healthcare system right now, and they will be very important part of our scheme as well.
Let's talk about some of the goals now, both short term and long term. What would you like to achieve through this scheme?
Well, I would like to achieve three things. One, I would like to increase the healthcare seeking behavior or hospital utilization by the poorest 40% people of the country. Right now, that's number one. And I'm saying that because if you look at the use of services by bottom 40% people in our country, that's about half of what the top 20% uses. And of course, you can argue that this is the population which has greater health needs, so they should be using hospitals even more, but they're using only 50%. So we want to increase their healthcare use, and they should not be shying away from going to hospital and seeking care and timely care. Because right now, when poor people get sick, they either don't go to the hospitals because they can't afford it, or they delay going to the hospitals, and when they go to the hospital, sometimes it's quite late. So we want to encourage them to go early and through this scheme. That's one. Second is that we've seen, we have numbers that every year more than 6 crore people fall into poverty because of expenditure on health. So we want to reduce that kind of catastrophic health burden and see or remove this, that we want to see that no one falls below the poverty line because of healthcare expenditure. Third thing is that if you look at the distribution of health services, it's very lopsided. Majority of health infrastructure, more than 50% of health infrastructure, is concentrated in 20 major cities, and much of the health facilities, dispensaries, about 70% of them are in cities. And the poor people mostly live in, or most poor people live in rural areas, and that's where we need to have more facilities. So we hope that through this scheme, we will be expanding services in tier 2 cities, tier 3 cities, and rural areas.
That is something that has been reported extensively in the media as well. Do we have the capacity really to deal with a scheme of such mammoth proportions? And do we have the qualified or skilled personnel as well to deal with this kind of a scheme?
You know, there are two issues. One is about the numbers, second is about the distribution. You're right that we should have a greater number of health professionals, human resources. We need to improve that. And therefore, this scheme has to be seen together with everything else that government is doing. There is a huge push to increase number of medical colleges. We are expanding number of AIIMS. There is a goal of having one medical college in each district. So, and also there is a goal to increase a number of health workers, nurses. So all that needs to go, and that will take some time. But at the same time, we have to see that whatever health professionals we have, they're highly concentrated in cities and big cities. So the distribution of those is also important. And if I am a doctor, of course, my tendency will be to go where the market is, where people can pay. So that's why you would see that a lot of doctors are concentrated in big cities where the paying capacity is. And now through this scheme, when we provide paying capacity to the poor, people living in rural areas or smaller cities, I'm quite sure that these doctors, these health professionals will see a lot of market and move to, or at least if not move permanently, but they'll increase their visits to these places. And so we'll see a total change in the picture of health sector in coming years because of this disruptive mission, which is going to give rupees or the paying capacity in the hand of 500 million people.
So you're suggesting that the mission is going to be a real game changer as far as healthcare and health insurance in the country is concerned.
Actually, game changer is the word which is used for this mission, but I think it doesn't go far enough. I think this is going to dramatically change the way the health sector, healthcare providers are distributed in the country, the way health services are provided in the country, and the way both public sector and private sector health facilities are structured in the country.
A scheme of this proportion is gigantic. It's something that no one has been able to pull off. No one has even attempted thus far. What do you believe are going to be the biggest challenges going forward?
Well, you are right that this is a scheme which is extremely ambitious. I think both in terms of the number of people covered, but also the features like portability. Those are not very easy to carry off. In terms of challenges, of course, there will be challenges, and you already identified one, which is the do we have people? And of course, we need to have more people, but at the same time, better distribution will work. But of the scheme of this size, for each state, there have to be three critical elements which have to be there. One, they have to have hospitals where they can provide services. Number two, they have to have a very reliable payer who can pay those hospitals. That payer could be either an insurance company or a trust, or a combination of insurance company and trust. Third thing is that they should have a system to identify the beneficiaries, and beneficiaries should know that they are eligible. So these three things have to be there: beneficiary, hospital, and payer. And all these three have to be connected through IT system, and strong and robust IT system. So now the challenges will be in terms of empaneling the hospitals, identifying hospitals, that we have sufficient number of hospitals. Our calculations are that for the scheme to provide services, we should have about 2.5 beds for about 1,000 families. So if you're looking at 10 crore families, we are looking at about 2.5 lakh beds to cater for this. So states will have to identify those beds, those hospitals, and not any hospital. We are hoping that they'll identify quality hospitals who can provide quality services.
Quality service at the end of the day is essential for any a scheme of this proportion to succeed.
Absolutely.
Because everybody seeks good health care.
Absolutely. So this is a scheme for poor people, but it's not a scheme for providing poor services. We are hoping, and we will be doing our best, that these 40% people, bottom 40% people of the country will receive the kind of services we at the top of pyramid receive and expect. So both from public sector and private sector.
You spoke about states. Several states have their own programs, of this proportion, or maybe not of this proportion, but they have their own schemes. Some of them are running excellently well as well. Does this mission or this scheme come in the way of those programs?
Absolutely not. Actually, it adds to those programs. And to be just taking a step back, I must say that it has been very useful that many of the states have good programs. So because we had many good models to draw on. For example, we have excellent schemes going in Rajasthan, Telangana, Tamil Nadu, Karnataka, West Bengal, and many other states were just starting the scheme, like Assam, Jharkhand. They were, and also there was a nationwide scheme, RSBY, Rashtriya Swasthya Bima Yojana, which was running in several states. So we've been able to learn from the experiences of all these states, and that has actually been useful. But this scheme, since in terms of coverage, both in terms of financial coverage, but also coverage of population, has been so ambitious that I think this scheme has pushed or encouraged all the states to think bigger. So most states were providing coverage of, say, 1 lakh, 1.5 lakhs, 2 lakhs, and this scheme is encouraging them to go up to 5 lakhs. Other thing which is this scheme is bringing is national portability, because most of these state scheme, none of the state scheme had this feature. They were insular and they were confined to their state boundaries. Now this scheme is national, and it brings in portability. Third thing is that it also brings in a lot of standardization, which will be useful for efficient running of the scheme. Fourth thing is that we know from experience that if we can have one risk pool, that's much more efficient rather than having segregated different risk pools for different states, because if we can combine all the risk at the national level, it is much more efficient and more cost effective. And so by combining all the states and having some standardized features and having portability, I think this scheme is bringing a lot of value even to those states who have well-running scheme.
You spoke, you called it ambitious on quite a few occasions. What is your implementation strategy for the scheme going to be?
Well, first of all, we are starting with the end date, which is 25th of September, which has been announced by the Honorable Prime Minister. And so we have a short-term strategy for implementation, which is the rollout. So for last 4 months, we've been working on all the guidelines and standards and just different processes, how to identify beneficiaries, how to bid for insurance companies, how to empanel hospitals, and all those guidelines have been put in place. We've been working on a one standard IT system which can be customized for each state. And now we are working on capacity building, identifying Arogya Mitras who will be going to be operating this IT system. So in the short run, we want to put all these pieces together and roll out the scheme in all states. In the medium run, we want to continue to improve all these features and see what is working, what is not working, and what changes need to be made. And in the long run, like the Honorable Prime Minister himself mentioned on the 15th of August, there will be a sense of how to go up from this 40% and how to collaborate or cooperate or integrate with other schemes which are going on, because we have many other health insurance schemes supported by the government like ESI, CGHS, ECHS, and how we can collaborate with
And
those
maybe
schemes.
even merge them.
Well, see, ultimately, I'm not talking about this year, next year. At one point, we'll have to think of merging all of these, because that's where most of the other countries have gone, because it makes sense to have one nation, one scheme, and that brings in. It is never a good idea to have separate pools. One risk pool is always much more efficient as compared to different risk pools.
The launch is, of course, on the 25th of September. By when can we take stock and understand that we have been able to achieve something great?
After the launch or before the launch?
No, after the launch, of course.
At individual level, you will see the impact right on 25th, because there will be hundreds of thousands of people who will be served through this scheme right from the day one, and they will see the impact of the scheme in their lives immediately. But at the population level, of course, it will take some time before people realize what this scheme has to offer, and they come and start to use services. So my sense is that we'll take about a year or so before the scheme gets its roots.
Okay. And talking about immediate benefit, of course, what is the eligibility criteria as far as the scheme is concerned, and who is covered by it?
Okay, that's actually a very good question, and this is one question which is asked most frequently, even when I visit my friends. So here, there is no enrollment, or there is no quote unquote eligibility per se. We have already identified those, or we have a list, and this list is based on SECC, socioeconomic caste census, which was undertaken in 2011. And in that census, there are deprivation categories. So there are deprivation categories from D1 to D7, and we have taken all of them except D6. So these deprivation categories are something like landless people, or if you are living in a house with one room only. So all those people are covered in rural areas. Urban areas, it's based on occupation categories, like if you are a construction worker, or a household worker, or a transport worker, and all those people. So when we look at that list, that's where with the number 10.74 crore families come from. And so these numbers and these names we have, and we have a software by which we can identify if they are part of the list or not. And so what we call, this is the entitlement based scheme, that people are entitled to get these services, and they're part of the scheme. and we are not going to add any numbers or any families at this stage. We might delete a few if we find some glaring errors that we've by mistake included some people who shouldn't be in this scheme to begin with. We'll take them out, but we'll not add any.
So the number can only go down but not up, at least for the time being.
For the time being.
Yeah, talking about the implementation phase, and so you spoke about how we're going to see the impact from day one. These people that you have identified, the list that you have created, are they going to get health cards? Are they going to get some kind of an ID card, or what is it? How does it really work? And what happens when they go to a hospital, an empaneled hospital?
Well, they will get a e-card, no plastic card, but electronic card, so that it eases their interaction the next time when they come back. So they will get a card. So first time a person comes to the hospital, we will check two things. One, whether the person is eligible. If I come and say that my name is Ram Kumar and I am from this village, so first the Arogya Mitra will confirm whether Ram Kumar is eligible, and then we'll confirm whether Ram Kumar is indeed Ram Kumar, because anyone can go and say I'm Ram Kumar and I should be given, and so Ram Kumar. So our preferred way is to confirm the identity through Aadhaar, but if the person doesn't have Aadhaar, we'll take any other means of any other photo ID which can be used to.
Government issued photo ID, basically.
Yeah. So, for example, voter ID or anything else. And once that is confirmed, then the person will get this e-card, which can be used next time. The e-card will have the picture of the person and a QR code, which will link the person to the family that he belongs to, because we need the family detail as well, because this 5 lakh cover is on family, not individual. So we need to link that person to the family, and that detail will be
What
there.
happens if someone exhausts this 5 lakh limit?
Frankly, 5 lakh is a big number.
It is, yes.
And our experience in many other schemes has been that very few people or very few families have gone beyond 1.5 lakhs. So we don't expect many families to go beyond 5 lakhs. But if there can be an unfortunate set of circumstances where maybe many family members have got sick or require healthcare attention, in that case, of course, they can cross 5 lakhs, and in that case, probably they'll have to pay. We really can't. The scheme doesn't cover it.
5 lakhs is the limit, and that's it.
That's it. And I'm hoping that maybe state governments will have some resources to take care of these cases where genuine needs are there.
Right. Can a hospital, an empaneled hospital, deny the right to admit someone under this scheme? And what happens if an empaneled hospital does that?
Absolutely not. Actually, our MOU with the hospitals clearly says that anyone who comes and is eligible should be provided services. And if hospitals deny those services, then we take action against the hospital, and we can also de-empanel hospitals based on this.
And another aspect that we haven't touched upon, of course, and something that is spoken about widely in the media as well, is about where the funds really are going to come from and how is this scheme going to be funded?
Well, this is a government-funded scheme, 100%. We don't have any co-payment or any premium that we are charging from the beneficiary, and it's entirely government-funded. 60% from central government and 40% from state government, and of course, the resources will come from the government, and we don't have any doubt that government is going to continue to support this. And as a matter of fact, if you look at our health budget, it's only about 1.2 to 1.3% of GDP, and Government of India has committed that it will go up to 2.5% in coming years. Therefore, there would be an increase in budget, and which will be sufficient to cover these needs. In any case, if our country continues to grow at the 6 or 7% every year, our budgets and our health budgets will also grow and will provide enough resources for this scheme.
I have one final comment from you before I let you go. 25th, of course, is not too far away from now. Any message that you would like to send out to the people of the country?
Well, we are working very hard to put this in place, but we are under no illusion that we have all the answers, and we are also trying and doing our best in trying to put all the elements and pieces together, but there may be some mistakes. And when the mistakes happen, I want them to be slightly more patient and work with us in resolving those issues whenever those issues come up. And also, I urge the viewers and through your channel to keep help us with two things. One, social supervision to ensure that there are no frauds and no abuses, and if they see any of that, they should inform us so that we can take action. Second is help us reach out to the beneficiaries and help us in terms of disseminating the details of the scheme, and so that they can come and take benefit from this scheme.
All right. On that note, then, I'll have to call it a wrap on this edition of To The Point. Thank you so much, Indu Bhushan, for joining me on the program and putting things into perspective for us. It was a pleasure having you on the program, and all the very best for the launch and implementation of the scheme.
Thank you.
That's it on this edition of To The Point. See you again next time.